I'm going to set the stage for a CHIP program by talking about this woman who is 90-year-old. Some of you might have seen this patient's history yesterday. And Chinese woman living in New York. Daughter is a pathologist at NYU. And she comes in with chest pain, ruled in for non-ST elevation MI. ECG showed ST depressions and diffusely with elevations in AVR. Troponin was high at 45. She was seen by cardiac surgeons, and she was deemed to be a surgical candidate. And because of this diffuse RCA disease, which is heavily calcified, ostial RCA was 90%. She had a prior stent placed in the distal RCA that is patent, but you can see extensive calcification. And the distal left main is the most problematic here. As you can see that there is a tight left main which is involving ostial LAD and ostial circumflex about 95%. So she was initially stable, and an LV-gram was done. This happened actually about last week. She came on a Friday, so roughly about a week and a half. So LV dysfunction, anterior anterolateral LV systolic dysfunction, EF is measured about 35% in this patient. So the question is this a patient that somebody should perceive that it is a PCI patient or a bypass patient? So as I said that she's a surgical candidate. I don't think that there's anything wrong with her to undergo surgery. Unfortunately, while waiting for surgery, she was given Plavix, about 300 milligrams in the emergency room, and hence we did a TEG study, which is a platelet reactivity testing that showed platelet inhibition with the Plavix, and so she was postponed for surgery and scheduled for surgery on Wednesday. And unfortunately on Monday morning she started having more chest discomfort, so 2 days after presentation, and she was given nitroglycerin, morphine, but pain wasn't actually relieved, and in fact actually she developed hypotension after that. And so now she started having significant and severe unstable angina. Obviously the LV dysfunction and the left main, both of them were not going hand in hand along with the hypotension. So this is the kind of patient that we would think that maybe after discussing with the surgeon, and the number one point is I told the surgeon that PCI is a possibility in this patient. So that's something we might discuss later. So I told the surgeon that yes, you are waiting for 2 more days for the Plavix to be reversed, but if patient crashes, can PCI be done in the patient? I said yes, this patient can have PCI. So that's the setup that we had, and after he evaluated the patient, and he said that patient should go for PCI as a heart team approach. So that alone may not be enough, so we did a right heart cath. I showed you a picture with the impella and all that, but before that I placed a right heart cath. Wedge was 32, PA pressures was 70/30, cardiac index was 1.7, so she was rapidly deteriorating, as you can see. And henceforth we proceeded with PCI in this patient. This is a right heart cath, and an impella is placed, and successful revascularization was done in this patient, and she actually is about to go home probably in a day or so. So this is what I will stop here, and obviously there's lots of discussion that we can have in complex high-risk patients. How do we define a complex high-risk indicated patients? And is it just a multi-vessel disease? Is it just hypotension, or is it LV systolic dysfunction? So, but it is a combination of all these three, in my opinion, that you have to think about hemodynamic compromise, patient comorbidities. As we see in this patient had a heart failure. She has unstable angina, non-ST elevation MI, LV systolic dysfunction, as well as complex left main coronary artery disease.